All right, last but not the least, as they say, my pleasure to introduce our last speaker for the day today, Mr. Sujay Santra, who is the founder, CEO of iKure TechSoft Private Limited, and who is also Ashika Fellow. I think I need coffee. Sujay started iKure with a vision to provide quality healthcare, which is affordable and accessible up to the last mile using technology and invention. Within just 6 years of his journey, iKure is catering to 3.5 million underserved people and have treated almost 500,000 patients across 6 states in India. Using the evidence-based evaluation metrics of improved health parameters of the communities through this model, Sujay is lobbying to challenge the national health policies to make holistic healthcare solutions that treat the root cause of diseases rather than just treat individual illnesses by medicine or surgery, the accepted paradigm of healthcare in India. Sujay, welcome.
Thank you. I'd like to thank HOSMAC for giving the opportunity to come over here and speak about iKure. So I'll just briefly talk about the whole journey of iKure, and just to say that I'm not a doctor. Prior to starting iKure, I worked in IBM Oracle for close to 12 years, last in Oracle as a solution architect, working on next generation CRM solutions, Fusion apps, before starting this venture. So some of the personal incidences led me to starting iKure, and we saw that the impact of technology was there in many areas, but not much in the healthcare space. And in healthcare, we saw that most of the technologies within the healthcare was designed around businesses, meaning that when a patient is walking inside a hospital, right from the patient registration and everything starts. And the moment the patient leaves the hospital, the patient loses all contact with the doctors. So that led to our own solution, which we call as WIMS, Wireless Health Incident Monitoring System, which is a cloud-hosted proprietary software. And we did on a very bottom-up approach. Although having worked in IBM Oracle and myself being an architect, we did not adopt a solution which was suitable for US and European markets, but mostly for the Indian market, which was very different from these countries. So the whole model was on a bottom-up approach, meaning that we understood the ground challenges, what works, what does not work, what kind of limitations are there on the ground, and how to provide the last mile healthcare. And we all know that there is a huge demand and the supply gap with doctors versus patients, only one doctor for every 1,800, 1,900 patients. And the only way that you would be able to solve this is how you would be able to use technology very, very effectively. So initially in the year 2010, 11, 12, we built on this technology domain, and then we understood that we had to depend on NGOs, which were again not very adapt to technologies. We had to depend on government, which were again moving in their own pace. And then we started on our own healthcare center, which is a one-window approach. We had seen that for any kind of a medical requirement or an incident, the patient have to a couple of options. They have to either go to a doctor, they have to either go to, which is in a government PHE. If the patient is lucky, they would be able to see the doctor. But for buying medicines, they have to walk an additional 5 to 10 kilometers. And in the rural areas, traveling for this much of distance is quite a lot. The other options are, they have to go to a quack, which are the informal sectors. And in some cases, they have to walk all the way to the towns and the hospitals. So then with our own distribution model, we understood that we have to provide a one-window approach, which is a rural healthcare center, meaning that once a patient is coming within our own facility, they would be able to get doctors, medicines, basic tests done. And in case they need access to secondary or the tertiary care, they would be able to go to various hospitals. So this was in a shift from the normal centralized model. I'm sure it's not, can you just move the slide? So in the central model, we all know that we have a hierarchical systems. We have the hospitals, and then the central district hospitals. Then there are CHEs, PHEs, Anganwadi centers, and others. In our distributed model, we have thought of a hub and spoke model. So I'll give the example of Torpa in Jharkhand, wherein we are working. This location, which is around 3 hours from Ranchi, more than 96,000 families are staying. Tribal population. Tata Trust and Pradhan have been operating in these areas for the last 15, 20 years, and they have been providing financial inclusion, women empowerment, agriculture. So through this period, these rival population, they have been able to earn a living, meaning that now they are able to grow pulses, broccoli, millets. But one of the important facts that they understood is just because healthcare was not available, more than 50% of their savings was getting lost. And then through our collaboration between iKure, Tata Trust, TRI, which is Transforming Rural India Initiative, we have set up this model, which is a hub and spoke model, wherein in the Torpa town, we have got the hub, which provides the physical doctors, medicines, various basic tests being done. And we cover in this entire block by mobile medical teams a few days in a week. Let's say on Mondays, Wednesdays, morning 9 a.m. to 12 noon. The doctor gets to see around 50 to 60, 70 patients. And out of which maybe only 10 to 15 patients may need follow-up. And in that case, we have something called as community health workers, who are none other than the members picked up from the community, mostly women in the age range of like 20 to 45, 50 years of age. They are trained and they are given medic bags and the smartphones. So these community health workers, they are able to capture all the vital information from these patients. And then once they come within the internet zone, like we want to place a fact that in these remote locations, these are absolutely last mile, meaning that where it's across the river without any bridge, through the jungles, across the hills, we are there. And once these community health workers, they come within the internet zone, this data gets synchronized back to the cloud, and that's made available to the doctors. So the doctor gets to see these informations, and then they have to act like nothing to worry, change the drug, change the dosage, or bring the patient to the hospital or to the doctor. Next slide, please. So while doing in this hub and spoke model, we have also understood a couple of very important factors, meaning that in the rural areas, the problem is not just the unavailability of the doctors. We have been able to reach some of the locations wherein we are the only first time in the last 50, 60, or maybe 100 years, we have been able to provide formal healthcare delivery. And while doing so, we understood that even if the doctor is writing, iron and folic acid, the mothers won't take that, thinking that the baby would be dark in color, or they would be not be able to have a normal delivery. So we had to deal with multiple facets of challenges. These are societal challenges, cultural challenges, behavioral challenges, and through the combination of various messaging and dissemination, A, through the mothers, B, through the mother-in-laws, or the husbands, or the fathers, because the decision maker in the families are mostly not the mothers. They are the mother-in-laws or even the community. And through this multi-level approach, we had to educate them that what is right and what is wrong. We have been getting patients, for example, they are suffering from extreme pain. They are, laborers, agricultural laborers, construction laborers. They come with the problem of pain, and then they say, mujhe short chahiye, meaning that they want a steroid injection and they want to go back to the work just the next day. And then we had to really counsel these patients that these steroid injections are not good for your health. You have to go through a normal medication, physiotherapy, and then that should be on a long-term basis, you would be able to heal that. We did a project in Orissa, Kandhamal, and Raigada, extreme south, very, very interior, remote locations, and we saw that more than 90% of these communities were suffering from anemia. We asked the government officials, and they said that we have been providing iron and folic acid for last 50 years, nothing has changed. Then through agricultural intervention, we really, through our agricultural partners, we really taught them that how to grow pulses, broccoli, millets, and then these became the natural diet to their habit. And through these mechanisms, we have been able to treat these problems. Like, for example, we have partnered with University of Michigan, and we have developed a framework on mother and child. Through this framework, these community health workers, once they enter the data, they would be able to give various kinds of information. For example, in case of high-risk pregnancies, what are the various factors? In case of development delays in the infants between 0 to 24 months, whether the baby is able to throw a ball or climb up the stairs. So through these factors, we are able to treat these problems in a very, very distributive fashion. And now our objective is that how we would be able to empower these community health workers, because we can really guarantee that for the next 100, 200, or 500 years, we will never be able to solve the problem of doctors in these rural areas. So the only way to solve this problem is how we can enable and strengthen these community health workers. And we have been dealing with that in a very multi-pronged way, through technology, For example, we have partnered with University of Oxford, and we have developed a mobile phone fitted with a microscopic camera. And these community health workers, they would be able to go to these remote areas, capture 1 drop of blood. That would be doing an image analysis at the remote area, and they would be able to scan whether the patient is suffering from oral cancer or not. So these kind of technology innovations we have been able to do. Even in case of health cards, so these health cards are QR code based cards. Once the health worker are going into these rural areas and they scan within our app, the entire data gets pushed, and then the health worker would be able to diagnose these diseases. So some of these things are very, very, first of its kind, which we have been able to introduce, that gives a lot of transparency in the last mile. Many of them really have that. There are so many interventions running. Do you know that how many of the health workers are really reaching your patient's home or not? We do not know. But through these technologies, we would be able to do and enable that, yes, the health workers have really gone. They are able to do a biometric mapping of their the beneficiaries, and these are the data which can be mapped up to the last mile. So in our model, we know that we are a for-profit venture, and maybe we are one of the first model in the world which have been able to do a for-profit entity for the public health in the rural areas, primary healthcare. This is the year in 2016 we have broken even as an organization. So we have done a combination of model wherein we are able to earn the revenues through the patients. The patients are maybe buying health cards, which comes at around 600 rupees per family per year, which means only 10 rupees per beneficiary per month we are charging. And in addition to that, they can come on a transaction wherein the patients are paying only 90 rupees for doctor consultation and medicine. And we also sell our technology to various NGOs, governments, because our technologies are complete end-to-end, right from patient registration, billing, inventory, pharmacy, various kinds of data analytics, business intelligence, all of them are there in that product suite. In addition to that, we also engage in various CSRs. For example, in Kolkata, we have partnered with Kredai Bengal to provide the CSR for the construction laborers. We saw some very interesting facts. We saw that in the first year in 2014, there were many hospitals, but in 2016-17, we were the ones we were providing these screening. And in what we did is, our objective was not just to do camps in silos. We were able to create a story out of that what was the problem in the year 2015, let's say June, how it has improved over a period of 6 months, and how we would be able to monitor that. We saw some of the cases wherein the patients were extreme high BP, and they were asked to work in very tall towers. So through these counseling, through these behavior mechanisms, our health workers and the doctors, they were counseling these construction laborers, like what is good, what is not so good for them. So through these mechanisms, we have been able to create a sustainable healthcare delivery model. Now, one of the other factors in the rural case is convergent innovation. We know that in many cases, what happens, the problem is like we have so many healthcare specialists over here. Some of the major problems which we have learned is really health is not a silo. Health you really cannot separate from the other entities. Health is linked to water, sanitation, nutrition, and many other things. And through our convergent innovation, we really try to understand what are the various factors which is impacting health. If in a geography, for example, there is a block, the block has 1 lakh population, and out of 1 lakh population, if 90% of the population is suffering from disease X, then maybe something is wrong. It's not that the whole community can become patients. How do we learn, and that what are the various consequences that is impacting these issues? So through these convergent innovation, we try to do that. For example, with MIT Next Lab, we have designed a framework wherein we are trying to see that in case of an industrial, let's say, plant, how that industrial plant and the contamination water that is coming out of that is impacting health in that neighborhood. What are the various things? How do you link all these linkages and try to see and educate the doctors also that, okay, these are the parameters because of which these are the issues are there. And through various counseling, messaging dissemination, medicines, you would be able to go with a long-term solution. So iKure's organization model, definitely we have been able to provide community health workers at the last mile. Some very important factors, we see that initially when we deployed these community health workers and we gave them smartphones, it was not easy. This was way back in 2014 when we gave them, we did a study on how do you capture around 50 sets of data on a paper versus tablet versus smartphone. Initially when we gave them the smartphone, these were just village women. We saw that they were really very scared. They were not able to hold the smartphones in their hand. And even some of the gestures which seemed very obvious for us, like right swipe, left swipe, these were not so easy. And even in case of the problems where the problems of heat, sweat, dust in these areas, the engineers in the labs, they did not understand and foresee these kind of challenges on the ground. But at iKure, our strength is we understand the technology as well as the ground conditions. And that's why we have been able to do various projects. Even our technology is running in East Africa, in Myanmar, and several other countries, because we really understand that when you want to design technology solutions for the last mile, for the distribution network, what really would take to really think on various factors. These factors of the ground conditions, the factors of the people, the psychology who are actually holding that. And